Today, he's going to be talking about drug-eluting stents in the lower extremities and what role they have in our treatment of patients with critical limb ischemia. Steve.
Thank you, Dr. Sullivan. Let me try to, let's see. Having a little technical difficulty. Can everybody hear me okay, or do I need the mic? Is that all right? All right. Okay. Disclosures? None? So the treatment goals for critical limb ischemia are to preserve a functioning limb in the surviving patient, relief of pain, healing of wounds, and improved, maintained quality of life. The goals of this presentation today are to talk about critical limb ischemia, the background data on saphenous vein bypassing, angioplasty, stenting, and drug-eluting stents. This may be familiar to many people in the audience. 6-month data from the task group. Patients with critical limb ischemia at 6 months, 20% will die, 40% will be alive with an amputation, another 40% will be alive without an amputation. In terms of defining CLI, so that we're all on the same page, those patients with recurring ischemic pain requiring opiates for at least 14 days, ulceration or gangrene of the foot or toes, an ABI of less than 0.4, the toe pressure less than 30, ankle pressure less than 50, flat pulse volume waveforming, and absent fetal pulses. The Rutherford classification, very useful in terms of describing patients with peripheral artery disease, being asymptomatic at the bottom of the spectrum to major tissue loss at number 6. In terms of amputations, there's approximately 150,000 amputations for critical limb ischemia in the United States annually, with the perioperative mortality approximately 5 to 10% for below knee and 15 to 20% for above knee. When these patients do survive, nearly 40% die within 2 years of their first major amputation, and a second amputation is required in 30% of cases. Full mobility is only achieved in about half of BKAs and only 25% of above knee amputations. In terms of all the PAD studies out there, there are very few high-quality, randomly controlled trials to provide level 1 evidence in support of clinical decision-making in PAD. There are so many catheter-based devices that amplifies this problem. The industry is very highly market-driven. There are turf battles. Industry influences have become dominating factors in everyday clinical practice. In terms of some background information on surgical vein bypass, this is tried and true, 5-year limb salvage rates greater than 80% with non-healing ulcers or rest pain. Obviously, the need for adequate vein is there. Vein graft stenosis between 30 and 50% have been reported within the first 3 to 5 years, of which half occur in the initial post-op year. 5-year patency rates are 50 to 70%. So there is data on 5-year patency rates with surgical vein bypass. There's very few, if any, data on endovascular means going out to 5 years. Most studies that you'll see in the literature are 6-month binary restenosis, 1 year data, maybe 2 year, very seldom beyond 2 years. Limb salvage in the critical limb ischemic population undergoing bypass greater than 80% at 5 years, so very good. Unlike surgical bypass with vein, there is no consensus, no gold standard endovascular approach for treating advanced limb ischemia with endovascular means. However, the appeal for endovascular is that it is relatively safe and minimally invasive. Surgical options are preserved if early or late failures necessitate bypass. I'm not going to go into this point right now, but this is debatable. There are reports in the literature as recent as this year in JVS, Journal of Vascular Surgery, from the New England Vascular Surgery Group, Dr. Nolan, who talks about that you potentially do burn bridges if you if you intervene endovascular and have to go in later on for surgery. Lower major adverse event rate than surgery. Significant comorbidities and physiologic compromise of the critical limb ischemic patients would obviously be an advantage for a minimally invasive technique. The reduced longevity of the group as a whole may require less durability for adequate duration of limb salvage. And reintervention can be offered for late recurrence with similarly low morbidity and mortality. In terms of just sort of a general idea of durability, it's fairly well understood and agreed upon that surgical intervention tends to be more durable than endovascular. This is a study that was published in Journal of Vascular Surgery a few years ago, just looking at patency rates for crural angioplasty versus distal bypass. And as you can see, the angioplasty group in blue did not do as good in terms of primary patency or secondary patency. However, limb salvage was equivalent in both groups at 1 year. And this also gives you an idea, and this is supported in a lot of studies, that simple plano balloon angioplasty below the knee and even above the knee, average patency rates are in the 50% range, maybe give or take a little bit in that number. In terms of 3-year data, same study, again, the primary and secondary patency rates for bypass were quite good. However, you know, as you can see, limb salvage really no different. This is just to give you an idea that even though primary patency may be not so great at 12 months, you can see limb salvage is well preserved. And this is the general theme in lower extremity interventions you'll see with many different devices and techniques, that though patencies may not be all that great at 1 and 2 years, limb salvage is really respectable. So the basal trial, which many of you are familiar with, bypass versus angioplasty in patients with severe ischemia of the leg, there was no difference in overall survival or amputation-free survival by intention to treat assignment. For patients that are alive greater than 2 years, open bypass significantly improved overall survival, and there was a trend towards increased amputation-free survival. The basal trial is a landmark effort that has launched the era of evidence-based practice for advanced critical limb ischemia. So why the use of stents? The first infrapopliteal stent was a palmos placed for dissection, published back in 1993. Numerous cohort series followed. The obvious benefit is acute luminal gain, and you negate that acute elastic recoil that you get with just plain old balloon angioplasty. The expert stent, self-expanding below-knee stent, reported 1-year patency is about 75%, published in 2007 and again last year. These are fairly well-known trials comparing Nitinol stents. Now, this is the SFA, not below knee, in patients with variable lengths of lesions. In the absolute trial, the mean lesion length was 9.5 centimeters. In the FAST trial, it was 4.5, and the resilient, it was 6.5, comparing angioplasty to stent placement. And as you can see, except for the FAST trial, there was a significant benefit of stent placement compared with plain old balloon angioplasty. In this particular study that was published in the Cardiology journal back in 2004, compared angioplasty below knee critical limb ischemics for severe claudication, early and 1-year outcomes. This was the first study to demonstrate clinical and hemodynamic efficacy and safety of primary stent placement below the knee for critical limb ischemics and severe lower extremity claudicants. Most of the patients were critical limb ischemics, about 70%. AVI increased in all groups. Relief of rest pain and healing of ulcers and amputations occurred in almost 100%. In this particular group, there was a mixing and matching of various balloon expandable, self-expanding coronary stents. So why the use of drug-eluting stents? Despite the elimination of early interventional failures and hemodynamic improvements, the issues of late in-stent stenosis ranging from 20 to 60% have been reported, mainly due to neo-intimal hyperplasia and the success in the coronary bed. Drug-eluting stents, there are 3 main components: a backbone, polymer, and a drug. This is sort of early data because not all drug-eluting stents nowadays have polymers, and we'll get into that. Most designs use laser-cut stainless steel for the stent backbone. The thickness, length, and strut widths are variable. The variety of techniques to place the polymer onto the stent, and they all interfere with the cell cycle in some way. Sirolimus, an immunosuppressive, and paclitaxel, an anti-proliferative, limit neo-intimal growth of vascular smooth muscle cells. This is just an example of the Sirolimus Cypher stent, showing the stent platform, the carrier, and the drug, how it's applied. So in terms of current drug-eluting stents, back in 2003, the Cypher stent became available, followed by the Taxa stent, then later on the Endeavor stent, and most recently the Xience Sirolimus stent. Sirolimus, or rapamycin, is a fermentation product of Streptomyces hygroscopicus, discovered in 1977 as an antifungal antibiotic with immunosuppressive properties. It's lipophilic and therefore readily diffuses across cell membranes of vascular smooth muscle cells and leukocytes. It binds to an intracytoplasmic receptor. This complex inhibits a regulatory enzyme and thus blocks cell progression from G1 to the S phase, and therefore limits smooth muscle cell replication and proliferation. Paclitaxel is an anti-neoplastic agent originally isolated from the bark of the Pacific yew tree, approved by the FDA for breast and ovarian cancer way back in '92. Again, it's a lipophilic molecule and therefore will diffuse across cell membranes readily and has a stabilizing effects on microtubules. It inhibits the mitosis of smooth muscle cells as well as inhibits cell migration. This reduces the infiltration of vascular smooth muscle cells and leukocytes into the zone of injury caused by the stent. Okay, so starting to review some trials with drug-eluting stents. The SIROCCO trial is a very well-known published trial looking at the Cordis Smart stent, comparing patients that received drug elution with Sirolimus with just the plain old Nitinol Smart stent. Patients were symptomatic with the Rutherford 2 to 4 class. SFA lesions were between 4 and 20 centimeters in length, and they were either stenosis greater than 70% or occluded. As you can see from the graphs, the percent diameter stenosis at angiography at 6 months was, although it doesn't say it on there, is not statistically significant, nor is the 18-month duplex binary restenosis in the drug-eluting versus the bare metal stent. In SIROCCO 2, lesion lengths were limited so that all lesions could be covered by no more than 2 stents. In this data, you can see that the mean luminal diameter was not statistically significant between drug elution and bare metal, nor was the 6-month angiographic binary restenosis. In terms of 2-year data, there was no difference in the restenosis rates between drug and no drug. The STRIDES trial, which was recently published, again, was another SFA proximal popliteal study looking at everolimus. This particular trial, the drug elution time was prolonged compared to Sirolimus. It was a prospective, non-randomized trial, Rutherford 2 to 4. Arteriogram and duplex at 12 months. In this particular trial, duplex stenosis greater than 50% was defined by a peak systolic velocity greater than 2.5. Primary patency at 94% at 6 months, but down to about 70% at 12 months. The restenosis rate at 6 months was 14%. There was excellent response with ABI up to a year, and there were no stent fractures. So limb salvage was high, again, at 12 months, 90%, but this patency rate of 68% was not nearly as good as coronary stents and comparable to bare Nitinol. So similar to the SIROCCO data, drug-eluting stents have delayed but failed to conquer SFA restenosis, at least up to the publication of this trial. The Cypher stent is the only drug-eluting stent with below-knee indication. It's stainless steel, and it has received CE mark approval in Europe. 80% of the Sirolimus is released during the first 30 days. The remainder is released by the end of 90 days. There are several studies that led to the CE mark approval, and as you can see, I'll go over this a little bit. These aren't very great studies, but they are safety studies. Bozier looked at only 18 patients. There was no instant stenosis or occlusion up to 6 months of follow-up using the Cypher stent. Scheinart looked at safety and efficacy between drug-eluting and bare metal for infrapopliteal obstructions. The rates of amputation, need for bypass surgery, or target lesion revascularization were all statistically better for drug-eluting stents. The SIRO-BTK study published by Comu at 7 months showed a primary patency rate of 97%. How they define primary patency is not clear. It was clinically driven, not necessarily ultrasound or angiographic. And then Ciablis, who published several papers, showed that the 6-month, 1-year, and 3-year data on patency rates and restenosis were better with drug compared to bare metal. This is the published study by Sirolimus in 2005. They looked at Sirolimus eluting versus bare metal after suboptimal angioplasty and critical limb ischemics. The 6-month primary patency rates were significantly better with drug versus bare metal. In the same study, a low rate of TLR, or target lesion revascularization, but again, comparable limb salvage. So despite the improvement in patency, there really is no difference in overall limb salvage. ABI increased substantially in all patients. Interestingly, follow-up angiograms were missing in about 25% of cases in each group. And the conclusion was that Sirolimus restricts the short-term neo-intimal hyperplasia in the infrapopliteal vascular bed. In 2007, the same author published data looking at the 1-year angiographic outcomes and confirms the significant benefit again with Sirolimus, but also points out that angiography was not done in 40% of patients in each group. In this particular study that was published by the same author in 2007, this time looked at paclitaxel. And as you can see, the primary patency rates, at least for paclitaxel infrapopliteal, are not nearly as good as they were for Sirolimus. This was a small cohort of patients, only 29. Limb salvage, though, was still respectable, 86%, despite a low primary patency rate, a high binary restenosis rate, and a fairly high repeat intervention rate. Renal disease and occlusions predicted low primary patency rates in this particular study. Looking at primary stenting of Sirolimus eluting versus bare metal, in this particular study published in 2009 shows a markedly improved low restenosis rate for Sirolimus, consistent with Sirolimus's work and as well as TLR compared to Sirolimus compared to bare metal infrapopliteal. So in terms of long-term outcome, 3-year data, Dr. Sirolimus had already published the 1-year and 6-month and 1-year, and now the 3-year data. Again, this is not randomized. Fairly low number of patients in each group. This was provisional stenting for suboptimal PTA result. There was selection bias based on the operator in terms of what stent to place. Angiographic follow-up in 80% of patients. Now, primary patency rate was very low in both groups, though it was better in drug compared to bare metal. Binary restenosis was quite high. Repeat intervention-free survival was better with drug. There was no difference in mortality nor differences in limb salvage. They did not look at wound healing differences. In this trial that was just published, as you can see, October of 2011, and this is probably one of the most significant trials that we'll discuss today, is the SFA PTA trial. And having just come back from the Viva conference, this was highly talked about. So this trial looked at Nitinol stents with polymer-free paclitaxel for lesions in the SFA and popliteal above the knee, and looking at 12-month safety and effectiveness results from the SFA PTA single-arm clinical study. This was a prospective single-arm trial looking at the SFA PTA drug-eluting stent for above knee, polymer-free, and had to have a greater than 50% diameter stenosis by duplex ultrasound defined with a PSVR of 2 as opposed to 2.5 in some of the other studies. So again, no polymer. The dose is 3 micrograms per square millimeter. It's a self-expanding Nitinol stent. It's flexible and durable. The stent had to be placed within the SFA or proximal popliteal artery, as you can see in the yellow dashed lines, the location, 1 centimeter below the bifurcation and medial to the femoral epicondyle. The reference vessel diameter was between 4 and 9 millimeters. In the randomized study, there were 480 patients. In the registry study, there were 792 patients. Looking at the registry study, all patients or all comers were included with Rutherford category 2 or greater. There was no lesion length limitation. Up to 4 drug-eluting stents could be placed per patient, with the longest stent being 8 centimeters. Multiple lesions per leg. Occlusions, restenosis, and in-stent restenosis could be included, and follow-up through 2 years. The currently available data is available at 12 months and 2 years. Looking at the demographics, you can see that about a third of patients had diabetes, high incidence of hypertension, smoking, majority were male. Baseline angiographic data, the lesion length was approximately 9 centimeters in length. And lesion characteristics, the TAS C&D comprised approximately a quarter of lesions, total occlusions in about a third, and in-stent restenosis occurred in 16 and 24% at 12 months and 24 months. In terms of just safety, stent integrity, and effectiveness, at 6 months and 12 months, very low fracture rate on this particular stent. In terms of death, amputation, revascularization, and worsening of Rutherford classification, the event-free survival at 12 months and 24 months was 87% and 78% respectively. Freedom from target lesion revascularization at 12 months versus 24 months, 89% and 82%. This is just graphically showing you the excellent TLR, low TLR rate. In terms of clinical outcomes, patients had a significant improvement in ABI, a significant improvement in Rutherford score, improvement in walking distance and walking speed. These are all statistically significant. Freedom from TLR, you can see again, even for TAS C&D lesions, the 12-month and 24-month data was excellent at 86 and 75%. You can see a trend that as lesion length increased, there was a slight decrease in, or increase in TLR, I should say, but still very good. When you compare TLR rates at 12 months to the Nitinol data that I showed you earlier, the Resilient FAST trial, you can still see if you match these patients up in terms of lesion length and Rutherford score, in all categories, the Zilver PTX outperformed the corresponding Nitinol bare metal stent. So the Zilver stent appears to have excellent durability. Results through 2 years show no safety concerns and favorable effectiveness. When you look at the 12-month data on this Zilver PTX stent, you can see that the primary patency rate is extremely good. It's 86%, which is one of the highest, if not the highest, primary patency rates for stents in the SFA, with a very high freedom from TLR rate and a very low stent fracture rate. When you go out to 24 months, you can still see an excellent primary patency rate up to 75%. Now, shifting gears a little bit, going from the SFA back to below the knee and critical limb ischemic patients, there are 3 trials that are underway. 2011 is the Destiny, Achilles, and Yukon BTK trials. The Destiny trial is a randomized trial looking at patients with the Xience drug-eluting stent versus the multi-link bare metal stent. Primary patency rates at 1 year were 85 versus 54% favoring drug, and TLR was 9 versus 34% favoring drug. The Achilles trial randomized critical limb patients with the Cypher stent versus angioplasty. The binary restenosis rates after 1 year were 19% with Cypher and almost 50% with angioplasty. And then the Yukon BTK trial compared a proprietary non-polymeric Sirolimus stent to the same uncoated bare metal with 1 year patency rates for drug of 81 versus 56 for bare metal. So after 1 year, all 3 randomized trials strongly endorsed the superiority of drug over balloon angioplasty or bare metal stent. Just a little closer look at these trials. The Achilles trial, again, was a prospective, randomized trial looking at the Cipher Select plus coronary and infrapopliteal stent for infrapopliteal disease. Patients had to be Rutherford 3 to 5, have de novo or restenotic after PTA-only lesions in the tibial arteries. The target vessel diameter was between 2.5 and 3.5 millimeters. Stenosis greater than 70%. Maximum of 2 vessels in one limb, two lesions in one limb, with a maximum lesion length of 120 millimeters. Maximum of 4 stents within a vessel, or in total for 2 lesions. So looking at intention to treat and as treated for the Achilles trial, the 12-month binary restenosis rate you can see is significantly less in the drug or Cipher stent compared to angioplasty. Looking at the subset of patients with diabetes, you can see a significant improvement or decreased binary restenosis with Cipher compared to angioplasty. There's no significant differences in death, target lesion revascularization, target vessel revascularization, amputation or limb salvage, and stent fractures. Significant difference in Rutherford class from baseline to 12 months favoring Cipher. The Yukon trial was the first prospective randomized multi-center double-blind trial of a polymer-free Sirolimus eluting stent versus placebo-coated bare metal for either intermittent claudication or critical limb ischemia for de novo lesions below the knee. So it's a polymer-free Sirolimus stent coated with a 2% Sirolimus containing solution. 161 patients were enrolled with a mean lesion length of about 32 millimeters. The ABI had increased from 0.48 to 0.84. The differences between the 2 groups were not significant. There was a significant improvement in the Rutherford classification favoring drug versus bare metal. And the overall mortality group in this particular cohort, 23% in the critical limb ischemics and 9% in claudicants, reflects the limited life expectancy of this severely diseased patient population. Just to graphically show you some of this data, the primary patencies of the Yukon stent, significantly better, as were the secondary patencies. Again, limb salvage, though, not different, 98%. So despite these improvements in patencies and increase in cost, you're not seeing differences in limb salvage. The Destiny trial, drug-eluting stents in the critically ischemic lower leg trial, is a physician-initiated prospective randomized multi-center trial comparing the implant of a drug-eluting stent, the Zion stent, versus bare metal in the critically ischemic leg. Rutherford classification 4 to 5, lesions less than 40 millimeters with a maximum number of stents of 2 per patient. 6-month duplex primary patency rates favored drug over bare metal. And you can see out to 12 months on this slide that there was a significant improvement in patency rates for drug compared to bare metal. So I'd like to conclude by saying that drug-eluting stents are associated with favorable primary and assisted primary patency rates, amputation-free survival, and late lumen loss. You can avoid early stent thrombosis by the use of drug. Of course, we await larger randomized controlled trials. Cost issues need to be taken into consideration, and at least for now, these drug-eluting stents are here to stay. Thank you for your attention. Anybody have questions? Oh, yeah. Yep.
Randomized trial, I think, compared to experimental. Really superior. Now, second, a couple weeks ago, went through FDA to be on the market.
Right.
That's probably going to cost, but
right.
I think we should put them in the study.
I think the data is good. I mean, if you talk about how many lesions need to be treated to avoid a reintervention, I don't know what that number is, whether it's 6, 7, or 8 limbs. I think I heard that these need to be treated to avoid restenosis. It could be cost effective. You know, if you're not having to reintervene on these lesions, then maybe down the road you're actually saving money. But in terms of limb salvage, you know, the data is just not there in terms of, you know, amputation-free survival, overall limb salvage. But, you know, you definitely, according to this trial, patency rates are so good that it may end up being cost-effective.
Just a comment. I think, I don't know what percentage that is, what all the various studies show, but I think
it seems to be about 30%-ish, 40% in that general area.
Maybe that's it. I think the reason all those bars for limb salvage are always the same is that besides the sort of strategy for treatment of diabetic limb-threatening ulcers versus truly ischemic gangrene is very different. So xylitol makes, boy, if you have a heavy smoker, critical limb ischemia, that patient, their reconstruction goes down because 5 times worse than the leg express diabetic. Get them over the hump, unload their neuropathic pressure points, and have long-term limb stem that achieve that. That would find that diabetic sort of treated or, you know, it's skin heal. I don't know. Data will bear that out.
Yeah.
That's my case time, but it's my time.
Right. So, I mean, to that point, I don't know, based on all the trials, what, you know, these patients that are being published in these trials are not pure neuropathic ulcers. These are neuroischemic ulcers. These are all patients with severe obstructions or stenosis. So, in that subset of patients, they're showing improved patency rates, but not necessarily higher limb salvage rates. So the question is, if you're going to follow these patients post, you know, over time with repeat ultrasounds and detecting elevated velocities and then re-intervene to improve your assisted patency or secondary patency, isn't it easier to intervene on a lesion that is developing a stenosis than it is to intervene on a lesion that's completely occluded? So perhaps we're buying time with these patients with drug-eluting stents. We are getting them to heal with less reinterventions, with less cost. The more reinterventions we do, the more chance of complications there could be with each intervention. So, I mean, I can see the advantage and utility of putting drug-eluting stents, but overall, you're still not seeing improvements in limb salvage.
Aren't these trials selecting out patients who may have less severe disease? They're only taking patients who would require stents, is that right?
You know, some of these trials are putting 2 in, but other trials that have looked at this have put 3 and up to 4 stents in patients.
The right side is
Yeah.
You're getting rid of
and you're those patients not even candidates for intervention. So it's going to be, very often patients come to us now, I want to send that out. And this fall, patients come in. In fact, they ask me now, I have drug-coated stents in my head. And up until now, so I ask them if over time, from the corners, how do you manage? You put drug-eluting corners in everybody?
Yeah, it is. Guys, like the long-term data and the economic data really, I think when we started, we limited it, you know, small, diabetic, those ones that have really high including medicine and I think some of the newer economic data that you know, long term and some of that might be best. So I think we now take maybe more targeted approach with a large diameter investment support and probably find experimental. You know, most of them intermediate and more.
this probably expensive. It's $1 billion market. Combination of staff also as that went in and increased health market. That's before $2 billion not sold.
That's amazing. We initially had this capability where, I mean, with the patients, every 6 to 9 months, they would come back and see the notes. And, you know, we just tell them feedback, like, you know, all of it.
I have a question for anyone. One can't help but being suspect. Certainly you're helping their quality of life. So they have high mortality. This seems that we're at home. We're ending up with all failure. And how do we get it overall? PhD, authorization, multiple mobility. There's anything that we can do to say yes, to maybe shift the mortality. We need a project that's I'm just surprised that you know, organizations like government and healthcare would care for these patients. I'm amazed. The ultimate of all of them. The government subsidizes smoking, and then they subsidize that. So, I mean, if you look at smoking, that's the other thing about this part, too, is it sits around quietly without causing much trouble. So, like, that's 10 years before or after the coronary stuff. Most patients haven't been covered coronary by the coronary, right? Vulnerable coronary. Something which should have find out like
Dr. Alexander?
The percentage breakdown that less this is bad. I mean, wanted to ask a question about that. You've just done all these different studies.
Yeah.
Is there a standard as to how long to get platters in both arms and respect to what we do with and platters life? With respect to that, I like where you're not problems all the time. Taking top platters.
Yeah, so the studies are very variable in terms of the length of time patients are on Plavix, but a minimum of 1 month in most of the peripheral studies for Plavix. Some out to 6 months. Mm-hmm.
I'm sorry, were those for Rutherford? 1 month?
Mm-hmm.
Well, we're staying out here. There's some new data that came out in 5 or 6 months. I think it's test on stent, and some stents more so big stents on those, and others. I backbone now has movement in that area?
There is. There's really nothing significantly published yet, but there's certainly studies being done with bioabsorbable stents, some with drug coating and some without. And there's also a fair number of studies being done with balloon-coated or drug-coated balloons, which I don't know the data in the coronary, but at least in the peripheral seem to be encouraging. There are several studies, FEMPAC, Thunder, and Nick Levin, for 3 different studies in the periphery that showed favorable results with drug-coating balloons, leaving nothing behind, basically.
I'm interested in power primarily because different companies have been having very well power.
It can be. They talk about the polymer being a nidus for inflammation, which is the reason why some of these stents are coming out polymer-free now. That's my understanding. Yeah. That's the thing, because it's a balance. You want growth over the stent. You want a layer, but you don't want a significant hyperplastic response, right? So they can prevent that significant response for a period of time until you're off the plavix, and then you're exposed to for thrombosis once that effect is the plavix is gone.
So we won't face that in the periphery really. For thrombosis is a large vessel that's not stenotic, so this is more of a problem with coronaries.
Yeah, I mean we would never end up facing that if you gas some top of that like for a while. I mean, we really thinking ahead, like patients going to need surgery or something, but it always because they're not always uncovered. It's just not bad. It's all in the one early on.
Yeah, I think, one thing you can say is that drug-eluting stents clearly have decreased reinterventions, improved patency, but in terms of translating to clinical efficacy, healing of wounds remains to be seen. You can see that equivalent in terms of limb salvage. And these patients with limited life expectancy, like Dr. Alden said, you just may want to get them to heal their wound. And that may be, 6 months, 3 months, 6 months, a year. And they may not live more than 2 or 3 years. So, to put that kind of money, this technology into those particular patients may not turn out to be one.
Thanks a lot.
Thanks.